So, hello everyone. Today we're going to start our series on toxicology that we are planning to do in the next 1 month or so. So, today we are going to just have a general overview on how to approach a patient with a suspected poisoning. And how- a lot of us might be having some wrong ideas about what toxicology actually is. We might be thinking that toxicology means that there is one poisoning and we give an antidote, then everything is fine. So unfortunately, it doesn't actually work like that. And you will understand that most of the poisoning that we present to us uh, don't actually have an antidote or don't actually need an antidote a lot of the time. And second thing is that the backbone of toxicological management, 80-90% is going to be supportive care. So without good supportive care, patients are not going to have good outcomes, regardless of whether they got an antidote or not. So when it comes to toxicology, there's a priority list that might help you understand just how you should approach a patient with a suspected poisoning coming to the emergency. So our first priority is always going to be resuscitation. So primary survey, ABCD, you see what's wrong, then you assess, you try to deal with that first and foremost. That is your number one priority, especially if the patient is visibly unstable. And after you sorted that out, or if the patient is otherwise stable, then you go on to your assessment part where you do your history, your physical examination, and relevant laboratory investigations. Uh, so side by side, you have your decontamination as well. It's not like you when you're doing decontamination. Side by side, you do have to consider decontamination in the exposures where you actually feel that this could be a potential threat to the healthcare workers as well. So in that case, you have to do a decontamination first before you actually go into your assessment part. So both those things go hand in hand somewhat. And finally, you have your elimination strategies, enhanced elimination, which is having your least priority because it is rarely applicable and the clinical utility is often doubtful of how useful those strategies are. So now, coming to the primary survey, you go for ABCDE approach. So basically, A, airway patent or not. So the old concept used to be that if the patient's ECS is less than or equal to 8, then you have to intubate the patient. Recently, there was a trial that came out called the NICO trial, which basically showed that the patient with the toxicological overdoses, perhaps we should not be intubating them purely on the basis of their GCS. Again, a very, very controversial topic, and a lot of it will depend on what kind of place you're working at, whether you can actually provide good monitoring, close monitoring of particular patient for a long period of time. So all of that will also go into whether you're actually going to intubate the patient right away or not. But definitely you have to look for other things like patient is conscious, patient is having lots of secretions. So all of those things will factor in to whether you are going to consider a very quick intubation or not. Breathing part, respiratory rate and respiratory rate, very, very important. And we'll mention about this a little bit more shortly. Circulation part, if the patient is in shock, you should consider IV fluids and inotropes. So how much IV fluids you are going to give depends on the type of poisoning, whether the patient was having a lot of vomiting, diarrhea, and all. In that case, there will be a lot more scope of IV fluids. If there was, if it's more like a cardiac depression kind of drug leading to shock, then perhaps you'll have to go for inotropes a little bit earlier. So that depends on the type of toxin basically. Visibility, very, very important. Assess for the GCs of the patient, assess for the glucose of the patient, assess for the pupils of the patient. Extremely important when it comes to toxicology. Also, always assess for any focal neurological deficit, any kind of lateralizing signs. Because if you're having any lateralizing signs, you have to consider that this is not actually a pure toxicological emergency. There might be some kind of intracranial pathology as well. So do not be having the notion that patient with some kind of toxicological overdose is only going to have features related to that. Patient with toxicological overdoses can present with trauma. So these things can coexist. So the patient with some kind of overdose, they might have hit their head, they might be having an EDH. Perfectly possible. So you have to have a high index of suspicion for all of these things. Environmental part, very, very important to have to record the temperature, because hyperthermia and hypothermia are both possible. Patient with psychiatric disorder, patient with toxicological overdoses, alcohol overdoses, all of these things, they might become, uh, unconscious on the roadside. They'll be completely exposed to the environment, so they can be at risk of both hyperthermia and hypothermia. All of these things, again, you have to keep in mind in all of these scenarios. So what if the patient is actually presenting to you with a toxicological overdose, cardiac arrest, I'm sorry. So there are a handful of interventions that you can consider during the cardiac arrest. So sometimes you can have specific antidotes if you are very, very certain that this particular drug or toxin caused the cardiac arrest. Then you can consider things like Digifab, atropine for OP, anti-snake venom, naloxone for opioid, etc. If you are very, very certain that this particular toxin led to the cardiac arrest, you can and an antidote is available, then you can consider these things. Any kind of sodium channel blocker toxicity, you have to consider soda bicarb. So that is the main thing with things like TCA overdoses, and we'll speak about that when you're doing some classes on TCA toxicity. Local anesthetic systemic toxicity, that is where your liquid emulsion therapy comes into play. And CCBs and beta blocker toxicity, you will consider high dose insulin therapy. So what is the evidence that of these things in cardiac arrest? Not great, because you obviously in all toxicological emergency, the problem is that the quality of evidence that we have is actually very, very less. And when it comes to toxicological cardiac arrest, so it's basically zero. So all of these are basically expert opinion types of things, but these are all reasonable things to consider along with your routine ACLS. If the patient is having hypoglycemia, obviously you are going to give dextrose. So, Vignesh, how much dextrose would you generally give in the patient with the hypoglycemia?
If we use 25% dextrose, we can basically give 100 ml, that is around 4 ampules.
So basically, you'll give around 25 gram of glucose. That is, if you're giving 25% extra, that will come to about 100 ml. If you're giving 50% extra, that will come around 50 ml. So basically, go to give around 25 gram glucose. That will increase your glucose blood sugar by around 100 milligrams per deciliter. Then you start from dextrose containing fluids and under the patient's sensorium improve. So, but that is the basic thing that every MBBS graduate should be knowing. Arrhythmias, when it comes to toxicological arrhythmias, it's a little bit different compared to what we usually know with regards to ACLS. So we have to correct all other problems. You correct hypoxia, you correct any other metabolic abnormalities that might be triggering an arrhythmia, like any kind of potassium abnormality. Try to consider any specific antidotes if available, but in general, don't give antiarrhythmics for arrhythmias due to toxicological overdoses, because most of the arrhythmias are generally going to be caused by sodium channel blockade, and a lot of our antiarrhythmics are actually having that kind of property as well. So it's very doubtful whether that is actually going to make things better or make things worse. So in general, try to not reflexively give antiarrhythmics for arrhythmias. Also, you can have tachyarrhythmias with tricyclic antidepressants, which might mimic VT, because it will broaden the QRS complex and it will cause tachycardia. It might confuse you with VT sometimes, But in that case, you can give a trial of soda bicarb, and generally the QRS will start to narrow. And that is a big clue that it's not actually VT, but it's actually just sodium channel blocker toxicity. Seizures, again, seizures, the management in toxicological emergencies slightly different from what we do generally. Again, first line is the same: benzodiazepine, benzodiazepine, benzodiazepine. Second line, you can consider things like propofol and barbiturate. If you in specific overdoses, like your INH overdose, you can consider something like pyridoxine. Only that is only in INH toxicity. Levetiracetam, you can give. Nobody's going to tell you it's wrong if you do give, but the evidence that it will actually do something good is basically non-existent as far as I know. Phenytoin you will avoid in this kind of situation. Why? Because phenytoin has a class 1B antiarrhythmic property that's basically having some sodium channel blocker property. And generally, you would like to avoid the drugs with that kind of property in toxicological emergencies. Agitation, again, the therapy is going to be benzodiazepine. Benzodiazepine might have to do, will give very large doses of benzodiazepine as well. Try to avoid antipsychotic because you never know, there might be some mixed ingestion of antipsychotics. So them, and if you're forced to give them, try to use them with caution if possible, and try to avoid physical restraints if possible. Sometimes you have to use them if the patient is at danger of others as well as themselves. You might be forced to actually use physical restraint for some period of time, but avoid them if possible because it does increase the risk of rhabdomyolysis. Hyperthermia, why is it a problem? Because it can lead to rhabdomyolysis and DIC, all of these things. So any time you having very high temperatures, more than 40-41 degrees Celsius, you have to start cooling the patient. So how do you cool the patient? You can give cold IV fluids. You can do evaporative cooling. What do you mean by evaporative cooling? You just spray some water over the patient and apply some table fans around the patient. The patient will start cooling down. In a very severe cases, you might actually have to intubate the patient and sedate and paralyze. So those are in extreme scenarios. And then you can as adjunct, you can have your specific therapies in specific condition like cyproheptadine, serotonin, etc. But those are rarely going to come into play. The basic management is generally going to involve some benzodiazepines for agitation and cooling the patient. So hypothermia. So again, have a high index of suspicion for both ingestion and environmental causes because they can coexist. So psychiatric patient can become homeless, they can be found on the roadside. Alcoholic patients, they can have acute alcohol intoxication, they can end up on the roadside. They'll be exposed to the environment, they can have hypothermia because of that also. So don't always keep it in the back of your mind that something else could also be at play when you're dealing with these kind of scenarios. Okay, so having said that, so we have dealt with the immediate manager decisions when the patient comes rolling in the door. Now we'll just briefly look at how to do a assessment focused on the toxicological aspects. So as usual, we have your history and physical. In history, we have the 5 W. So who, what, when, where, and why. This is also very not just important to understand what happened, but also understand, it's also important for documentation for medical legal purposes. So these things are extremely important. And why means whether it was a suicidal or accidental ingestion, because suicidal ingestions generally tend to be much larger ingestions than accidental ingestion. So some of the key things that you should look for in the history is any kind of OPD papers, any kind of medication list that will help you get a quick idea about what kind of medication we might be dealing with. So if you're dealing with some unknown ingestion, try to get a photo of whatever thing that they ingested. If they didn't bring the container or something with them, because these days everybody has a smartphone. They can easily take a photo and send it on WhatsApp. So those things are very, very important. Again, timing and amount of injection, again, important in triaging. So get an idea about how sick the patient might become. So if the patient presents very early in the course, they might be deceptively stable, so only to crash later on. So you have to be very, very careful about that. And also get an idea about whether the patient took immediate or sustained release of formulation, because this will have a major implication of how long the patient is going to stay in the ED for observation. So sustained release of formulation, they'll have to stay in the ED for a longer duration of time. So coming to the physical examination, the most important things that are that you should look for in the toxicological examination is, one, going from head to toe. GCS, of course. Pupils, very, very important. If you're trying to diagnose which toxidrome the patient is fitting into, then pupils are the most important part of the examination. Temperature, I've already mentioned what the important of that is. Along with this, always look for any lateralizing sign. If you're getting any lateralizing sign, you have to get a CT done. Look for any intracranial pathology. Respiratory rate, don't trust a respiratory rate written by somebody else. That is notoriously going to be inaccurate. You have to count the respiratory rate by yourself for 1 minute. And whenever you see a respiratory rate that is suspiciously low, always consider the diagnosis of opiotoxicity. Opiotoxicity is something that we often miss here, because it's not something that we usually see a lot in our area. It might be more common in other states, but it is very easily reversible if you spot it quickly. So, but the problem is that we often don't spot spot the decreased respiratory rate. If you're that quickly, if you're not actually seeing a lot of this kind of patients, so respiratory rate is very, very important. Skin, most important thing is to decide whether the patient is diaphoretic or dry. So where do you actually look for, examine to figure out whether patient is diaphoretic or dry? Your armpits. So that is the most useful area to see whether the patient is actually diaphoretic or dry. So it will help you decide whether this is an anticholinergic toxicity or sympathomimetic toxicity. Then other things like tremors, clonus, etc., that will help you point towards a certain diagnosis like serotonin syndrome, etc. So briefly coming into some toxidromes. So the main things that we have are your anticholinergic toxidrome, cholinergic toxidrome, and sympathomimetic toxidrome. So I will just briefly just go through these. So anticholinergic basically means anti-muscarinic effects. So all the secretions of the body and all the tubes of the body have suddenly become blocked. That is what happens in anticholinergic toxicity. So along with that, patient will have hypothermia. The patient will become agitated, altered, delirious. We have vision abnormalities because patient will have mydriasis, and patient can have seizures. There will be dry skin, dry mucous membranes, and you can also have ileus and urinary retention as well. And urinary retention and all, that will also just increase patient's delirium and all. So things that I would like you to remember, common things are antihistamines and antipsychotics. So these are things that can present with anticholinergic features. Exact opposite of anticholinergic is cholinergic syndrome. So your classic dumbbells in OP. So here you have lots and lots and lots of secretion. So from each and every orifice, you're having lots and lots of secretion along with your pinpoint pupils. So that's the basically it's the exact opposite of your anticholinergic shock syndrome. Sympathomimetic basically has increase of everything. Heart rate increases, BP increases, sweating increases, increased agitation, and you can present with seizure as well. So these are things that you can get with things like cocaine and amphetamine overdoses. So this sympathomimetic toxicity and anticholinergic toxicity can be very similar in a lot of ways, but two things that can help differentiate it. One thing is, as I said, told you earlier, is your whether the skin is dry or patient is actually diaphoretic. So examine the armpits and see how the skin is. Second thing is to look at the pupils. In anticholinergic toxicity, the pupils will actually not react to light. In both cases, it will be dilated, but in anticholinergic syndrome, the pupils will not react to light. Whereas in sympathomammary toxicity, the pupils will still be reactive to light. Sedative hypnotics basically things like benzodiazepine overdose, alcohol overdose, patient become drowsy. So and due to increased inhibitory control over the brain, opioid, classic triad, CNS depression, respiratory depression, meiosis. Again, this keep this triad in mind. You will just see this triad in at one point or another. It doesn't need to be a drug addict. Could be that a patient was some end-stage cancer patient. They were on some opioids for chronic pain or something, and they overdose of that. So those are some very common presentations of opioid toxicity. So we have lots and lots of toxidromes actually. So I'm not going through all of them. It's very, so mugging up all of this right now is pointless. Just wanted to give an overview of the main ones, and we'll discuss each of these particular drugs when we deal with them in separate lectures. So diagnostic testing. So when it comes to toxicology, you don't actually need a lot of tests. So the most useful tests are number one going to be a blood gas. Basically, because blood gas will give an idea about how sick the patient is. So the patient is pH 7.4, and versus the patient is pH 7.1, obviously the patient with pH 7.1 is going to be much sicker. It helps in triaging when you're in a very, very busy emergency like ours. So that is one thing. And next thing is ECG. ECG will get to it. ECG will have give you a lot of clues about what kind of ingestion actually took place. Urine tox we are you routinely sending, but it's unfortunately very, very unhelpful most of the time. And obviously, in any reproductive age group female, you have to do an UPT. So if you don't do UPT, I promise you, you'll get your fingers burnt one day. So ECG, there are it can guide your management in a couple of ways. One thing is, if you see features of sodium channel blockade, what do you mean by that? You'll have widening of the QRS and you get a tall R wave in lead AVR. That means you're dealing with sodium channel blockade, and you should give some soda bicarb. If the patient's QRS begins narrowing after you give soda bicarb, that means the patient is responding. So that is one thing. Second thing is potassium channel blockade. So this can result in QTC prolongation, and if the QTC goes beyond 500 and all, that can lead to increased risk of torsade. So in those cases, you have to replete potassium and consider giving the patient magnesium. So ECG, definitely get it in any kind of patient with presenting with a toxicology emergency in which you are not actually sure what kind of injection took place. Urine tox often sent not very useful. Why? Because you have lots and lots of false negatives, lots and lots of false positive. It's a massive list. I have not even included that list in this lecture because it's huge and practically it's not possible for anybody to actually study that list also. Second thing is that it is basically qualitative, doesn't actually tell you whether how recently the ingestion took place a lot of the time. It can be costly, and it's not the cost benefit ratio is not actually there, and the ingestion might have happened a few days back, and the current percentage might actually have been completely unrelated to the ingestion. serum levels of certain drugs could be useful in certain toxicities. So paracetamol overdose, carbon monoxide overdose, digoxin, lithium. These are the places where serum levels can be useful, but practically it's very difficult to actually get them sent and done in the ED itself. And so perhaps in your center, you might be actually having better luck in getting these things, getting reports early. But practically speaking, we have some feasibility issues in getting these tests done, especially if the patient is coming in the middle of the night. Other things that you should consider, obviously, we routinely send CBCs, LFTs, RFTs, and all electrolytes. CPK, if you're thinking the patient could be at increased risk of rhabdomyolysis, especially the patient is having hyperthermia, seizures, patient is in a comatose state, in those kind of scenarios, always consider the possibility of rhabdomyolysis, then send your CPK in that case, and send your coagulation studies as well. Decontamination, if you in chemical exposures, radiological exposures, and other kinds of exposures like pesticides and all, make sure that you have adequate PPE. I don't know why people have stopped wearing PPE these days. Please wear a proper PPE. If you are trying to get PPE after the patient has actually arrived, it might actually be too late. So always better be safe than sorry. So sorry. Make use of your PPE which is available to you. Make the patient remove the clothing, bag it, and dispose it properly. And we have a particular protocol in our center for how to deal with these kind of radiological chemical emergencies. So we have a specific area outside the hospital where patients they can disabled patients will actually be able to shower with lots of water, so that can decontamination process can actually take place outside the hospital. Obviously, patients who are acutely unstable will not be going through that particular process. These are more for the more stable types of patients. Coming to other general methods like GI decontamination, under no circumstances should you actually try to induce emesis in any kind of patient. That will not end well, I promise you. Gastric lavage with the patient presenting within 1 hour, you can consider it. But we are a tertiary care center. Rarely do patients present to us that quickly within 1 hour of ingestion. So gastric lavage, we are not really having the opportunity to do that often compared to a peripheral hospital. Activated charcoal and whole come to in a little bit. Gastric lavage within 1 hour, and you have there are other things as well. It's not just doing lavage in whatever overdose. You have to avoid it in corrosive injection. Obviously, in corrosive, you are not doing any kind of lavage. Please don't do gastric lavage in corrosive injections. You consider it within 1 hour if it is an injection which where supportive care is not actually likely to solve the problem. For example, you'll have other injections like the patient took a few pills of benzodiazepines. Generally, that is not going to end up in a life-threatening condition. The patient will need monitoring, of course, but it's not a thing. Most of the time, you can get away with not doing lavage in those kind of patients, because lavage is uncomfortable. So you have to consider that as well. It is a very uncomfortable procedure for patients. Single dose activated charcoal doses around 1 gram per kilogram. Basically, it's a superheated carbonation material. It is taken PO. Generally, it is not recommended to put a trial tube slowly for the purpose of giving charcoal, because putting a trial tube itself can induce vomiting in a lot of people, and that can increase risk of aspiration, leading to chemical pneumonitis. So, due to charcoal, which is not fun. So how it works is that basically charcoal is going to be indicated the patient present within 1 hour massive ingestion. Patient is having normal sensorium and able to take orally. and airway is not that. So you can understand why charcoal is not going to be commonly given most of the time. Also, if you are having something like a benzodiazepine injection where charcoal actually absorbs it, but it's not really going to, give much of an added benefit, then you can avoid in those scenarios as well. So the indications of activated charcoal, you can remember as the killer C's. So cyanide, colchicine, CCBs, cardiac glycosides, cocaine, salicylate, TCAs, all of these things. If they are presenting early on, you can consider activated charcoal. So when is activated charcoal not recommended? There is a mnemonic for that called fails. And those of you who are studying here, this is a very, very favorite question of Jamshed sir. So fails. He loves this mnemonic. P for pesticides, like rupees, carbonates, heavy metals, hydrocarbons, any acids, alkalis, alcohols, iron, lithium, or any kind of solvents. In these situations, uh, activated charcoal is not recommended. So again, fails. Pesticides, hydrocarbons, heavy metals, acids, alkalis, alcohols, iron, lithium, and solvents fails. As activated charcoal, not recommended. Other things you can try is whole bowl irrigation with PEG. So one thing that you have to make sure before giving PEG is that patient is not having any kind of intestinal obstruction or EDS. So make sure that bowel stones are actually present before you start giving PEG. So the whole point is to reduce toxin absorption. So when do you actually consider these things? So large amount of iron ingestion, life-threatening CCP intoxication, body packer, body suffers, life-threatening lithium injection, lead injection. Don't try to buy heart everything right now, but it's a very select, very select amount of toxicity where whole body irrigation actually comes into play, and generally it's more important with your slow release medications. Other methods of enhanced elimination, one is multi-dose activated charcoal. So basically what we said earlier was single dose of activated charcoal. There's something called multi-dose activated charcoal where we give activated charcoal every 2 to 4 hours, urinary alkalinization, and extracorporeal removal. So multi-dose activated charcoal, basically 1 gram per kg, that is the same dose initially, followed by half of that every 2 to 4 hours. So you are not going to give it if the patient is having any threatened airway or bowel obstruction, obviously. What are the indication for multi-dose activated charcoal? You can remember by the mnemonic ABCDQ. So aminophyllins, barbiturate, carbamazepine, dapsone, quinine, ABCDQ. This is another very, very famous mnemonic, the indication for multi-dose activated charcoal. So the problems are also going to be vomiting, aspiration. So the basic problem with charcoal in general can lead to bezoar formation. So you're giving it again and again, can also form a bezoar, and that can lead to intestinal obstruction. Rarely, but it is possible. Urinary alkalization, very rarely indicated in only a handful of medication. So basically, it favors ionization, useful in acidic type of drugs like salicylate, where it will favor ionization of the drugs, and basically it will decrease absorption and increase the excretion of these drugs through the urine. So what we basically do is, first of all, you have to correct any hypokalemia, because you cannot give bicarb for a patient who's having a low potassium, because that will decrease potassium further and lead the patient into some arrhythmias. To correct any hypokalemia, then you start giving bicarb bolus followed by the isotonic bicarb infusion along with some potassium as well. Gold urine pH around 7.5 to 8.5. And you keep on monitoring your potassium and the bicarb every 2 to 4 hours. The complications are, one, going to be hypokalemia, obviously, and second thing is you're going to give fluid, so it's going to have some kind of risk of fluid overload as well, depending on the type of patient you're dealing with. Again, very, very few indication for urinary alkalinity. I told you for salicylate toxicity, and phenobarbital. Again, phenobarbital, not that big for a role these days, but it's a classic indication that you might be asked in theory. So very rarely are you actually going to find yourself actually considering this. Finally, coming to extracorporeal removal. So you have hemodialysis, hemoperfusion, and continuous renal replacement therapy. So these are the three options that we have. Hemodialysis. So again, one of Jamshed's favorite questions. What are the prerequisites for a toxin to be dialyzable? So basically, everything has to be low except one thing, that is water solubility. Water solubility has to be high. Everything else is low. So low volume of distribution, low molecular weight, low protein binding, low endogenous clearance. Okay. So these are the prerequisites. So what are the common dialysable drugs? So again, we have another mnemonic, I'm sorry to say, but it's called IV stumble. So isoniazid, valproate, salicylates, theophylline, uremia, methanol, barbiturates, lithium, ethylene glycol. So these are your indications for your, so these are your dialysable drugs, basically. Indication for dialysis will be different for each of these things that we'll learn in subsequent lectures only. But another thing that I'd like to mention here is that pharmacokinetics is slightly different from toxicokinetics. So if you're looking at some of the drugs like valproate and all, it might not actually fill these prerequisites, but once once patient the drug levels are actually in a toxic level, then it will actually become dialysable. So even if some of these medications are not actually dialysable in normal amounts, they might become dialysable in toxic amounts. So toxicokinetics is actually slightly different from pharmacokinetics. That's something that I wanted to mention here. Hemoperfusion is basically movement of toxin from blood or plasma onto a bed of activated charcoal. So it actually the drug needs to be able to bind to activated charcoal. So things like theophylline, carbamazepine, paracotoxin, you can consider this. TRRT, where is it useful? If the patient is having toxicological injection with hemodynamic instability. The problem with the other two modalities is that hemodialysis and hemoperfusion is that it can lead to hemodynamic worsen. You can worsen hemodynamic instability. So in life-threatening injection with hemodynamic instability, CRRT can be considered. So specific antidotes I'm not going into. I've given this table here. You can go through later on and like make the PPT available for everyone in the group. So you can go through these later, and we'll learn each of these antidotes as we learn about each of these drugs in subsequent lectures. So drugs that can cause a wide QRS, remember TCAs, sodium channel blockers, cocaine. Drugs causing hypoglycemia, obviously insulin and OHAs, but keep in mind your beta blockers as well. So beta blockers and CCBs, the presentation in overdose are going to be very similar. Only thing is that beta blockers will present with decreased glucose, CCBs can present with hyperglycemia. So that's the thing. So there are lots of drugs here. So always make sure that you measure the glucose in any patient with unknown ingestion. So tachycardia with hypertension. So you remember all the anticholinergics, antihistaminics, antipsychotics, etc., sympathomimetics, and all. Keep those in mind. Hypothermia with diaphoresis. Again, all of your antis will come into play along with your special syndromes like NMS and serotonin syndromes. Hypothermia, nice mnemonic cause. So carbon monoxide, opioids, OHS, liquors, that is alcohols, and sedative hypnotics. All of them can cause some hypothermia. Mitiasis, as we mentioned, sympathomimetics and anticholinergics. Meiosis, COPS. So cholinergics, carbamates, OPs, pontine hemorrhage, and sedative hypnotics. Keep this in mind. Bradycardia with hypotension. So again, very important differential, especially if you're in final year of MD emergency medicine. or DNB emergency medicine. This is an important thing to know. So beta blocker overdose, CCP overdose, digoxin overdose, and antidepressants. All of these things can cause a combination of bradycardia and hypotension. Hagma differential, I'm not going into it. You can go through this later. Radioactive toxin, heavy metals, entry-coated aspirin, salicylate, all of these are radio opaque, so you can see them on X-ray sometimes. So those were the main things that I wanted to say. So in summarizing all of these things, so mainstay is always going to be aggressive resuscitation and good supportive care. So without that, you are not going to get good outcomes in any kind of emergency. So identifying the toxic drum can help management. Urine tox, more or less useless. Rarely can give you an idea, a clue perhaps, but most of the time is useless. Things like activated charcoal, like gastric lava, are most useful within the first 1 hour, up to some say up to 4 hours, but most of the time it has to be a very, very recent ingestion. Remember the fails mnemonic for things that are where for situations where activated charcoal is not recommended. Urinary alkalization, whole ball irrigation, specific indications are there. And remember the list of dialysable drugs, IV stumble. So that was all for today. And if anybody has any doubt, I think this is the time to ask them. So please unmute them and ask any doubts.